Hello, friends. So today we're going to be talking about the different kinds of shock, but with a particular emphasis on cardiogenic shock. So, a shock is basically a situation or in a case where you have a patient's vitals are where his vitals are hemodynamically unstable. You have a blood pressure that's under 90 over 60, and usually the heart rate compensatorily is tachycardic in order to preserve, or like as a way to try to compensate, except in certain situations. So, a cardiogenic shock is actually one of those situations where you can find the heart rate to be diminished. Having said that, let's just go into it. A cardiogenic shock can be caused by many things, the most common of which is an MI. Recall that in your step one exams, you would be asked about, you would be given, for example, an ECG, and you would be shown different leads where there's a STEMI, and you can be easily asked which artery has been blocked that caused the myocardial infarction. Arrhythmias are very frequently asked in your exam, especially SVTs, VFibs, ventricular fibrillations. How do you manage it? And all this stuff we could discuss later. Heart failures, cardiomyopathies, you could think in terms of HOCM. They can cause heart failure. You have to know like that the the sarcomeres would be organized in series. If there's dilated cardiomyopathy, they would be organized in parallel. If if the cardiomyopathy is actually not in series, they would be organized in parallel if it's hypertrophic and it's not dilated. Keep that in mind as high yield. Myocarditis, viral myocarditis, influenza, keep that in mind. VSDs, valve defects. You can be easily asked about a case, for example, where someone has an RTA or a blunt chest trauma, injury, fight, whatever, and then the answer would be a cardiogenic shock because of an arrhythmia. You have certain drugs, beta blockers. Recall that beta blockers affect the production of cyclic AMP. So for a step one exam or a step two exam, even, you can be asked like, how would you treat this? How would you treat someone who OD'd on beta blockers? And the answer would be to give glucagon, and that's very high yield. So the path of phys is really simple. We're not going to be wasting a lot of time on that. But basically, cardiac output is low. Cardiac output, the heart's job is basically to do two things: to take the blood outside of the lungs and to give the blood to the vital organs, namely the brain and the kidneys. Therefore, a situation where the cardiac output is low, that means the pulmonary circulation is going to be filled with blood. Hydrostatic pressure is going to be elevated. You're going to have a pulmonary edema. Also, this is systemic circulation is not going to have adequate blood supply. That means you're going to have your RAS system activated. That means your kidneys are going to try to like have some sort of water retention. That means that the blood is going to be focused mainly to be directed to the brain, kidneys, as we mentioned. So your systemic vascular resistance is going to be elevated. How would I manage a cardiogenic shock? And this is important, especially for step two, step three. Recall the main thing that you have to do for any kind of shock, any situation, any exam, actually, always keep the ABCDs in mind. Always think in terms of how do you protect the airway, how do you fix the circulation, how do you fix the breathing. So a situation like this is really simple. You have a lot of fluid in the lungs. The first thing you're gonna do, you're gonna elevate the leg. You're gonna ventilate the patient because he's hemodynamically unstable. You're gonna elevate the PEEP in order to force the fluid outside of the alveoli in order to clear the alveoli. If someone's taking antihypertensive, you're gonna have to stop. You have to treat the underlying cause. That's very simple. So a patient who's got wet and cold, what does wet and cold mean? So cold, that's basically we're trying to refer to the hypertension. Wet because there's a lot of fluid in the lungs. You have to clear the lungs. So the first thing you're gonna have to do is you're gonna have to maintain the blood pressure. You're gonna have to fix the cold first. And you can use inotropes or you can use vasopressors, ideally norepinephrine, to maintain the blood pressure. After that, you have to treat the wet. And how would you treat the wet? You have to get that fluid outside of the body. And the ideal way to do that is through Lasix infusion. We put the patient on Lasix infusion, like Lasix rate 1 or Lasix rate 2. That's something that we do all the time in an ICU setting. And this is actually kind of a challenging situation because Lasix can cause hypertension. So that means that you have to keep in mind that you can't do that unless the patient starts maintaining a blood pressure above 90. Right, and the systems resist. You have to like start treating the main cause, right? You have to if someone has like you have to start treatment for like acute like for the heart failure. You have to start fixing that. You have to decrease the preload. You're going to decrease the preload initially. You're going to decrease the afterload. So a lot of things that we're going to do. A lot of things we're going to talk about later. What about dry and cold? Okay, so in any ICU setting, if a patient comes in with a low blood pressure, no pulmonary congestion, no pulmonary edema, no B lines on his chest X-ray. All right, the first thing you're going to do is you're going to give fluids. It's very often that you find a patient that comes in and is on like 4 liters, 5 liters per day of fluids in the ICU, plus NOR, plus Dobitrex, plus Milrinone. This stuff is very common. And with the shock persist, you're going to give a vasopressor, ideally norepinephrine. You're going to administer inotropes, right, for the hyperperfusion. Okay. You don't use dopamine for step 2 or step 3. Usually that's not the answer. Dobutamine, keep in mind that works through beta 1 receptors. It's highly specific, but it's also highly arrhythmogenic. And keep in mind the mechanism of action of Mirinone is also really high yield. Also, a high yield point is to keep the IV fluids can worsen the cardiogenic pulmonary, right? That makes a lot of sense. I mean, his lungs are already congested, they're already filled with fluids. You're not going to give him more fluids, right? So take care of that. And you have to avoid inotropes is someone with like severe aortic stenosis because the left ventricular outflow tract is obstructed. The heart can't is like pumping, but it's pumping with the opening to it. It's just closed. So then what's the point? Instead, you have to start thinking in terms of TAVI. You have to start thinking in terms of treatment of the aortic stenosis. All right, so now we just talked about cardiogenic shock in particular. But how am I going to differentiate that from other kinds of shock? And this is super, super, super high yield for step 2. So keep in mind, the best way to measure the function of the left side of the heart is through the pulmonary capillary wedge pressure, which basically estimates the ability of the heart to take the blood from the lungs and send it all over the body. When the left side of the heart is malfunctioning, the pressure is going to accumulate in these capillaries. So keep that in mind. Now, that's just one part of the equation. The cardiac output is the estimate overall, and the systemic vascular resistance, okay, is basically the pressure of the veins throughout the blood system. Okay. So in a situation where you have a hypovolemic shock, there isn't enough blood to be going around. The cardiac output is going to be diminished. Precapillary wedge pressure is going to be diminished. The heart's working fine. The afterload is going to be hard because there's going to be generalized severe systemic vasoconstriction, especially in the initial phases, in order to maintain the blood pressure. When it comes to a cardiogenic shock, the main problem is the heart. That means the cardiac output is low. Left side is not going to be able to adequately drain the blood from the lungs. So that means the pulmonary capillary wedge pressure is going to accumulate, and that means it's going to be elevated. And the afterload reflexively is going to be high. Obstructive shock is going to be almost the same thing. Again, cardiac output is low, wedge pressure is usually elevated, afterload, again, reflexively. Okay, so when would the afterload not be elevated? And you would see that frequently when the body can no longer embark on an adequate sympathetic response, is in situations of neurogenic shock, anaphylactic shock, or a septic shock. And you would see that like the toxins themselves within septic shock or the immune response in an anaphylactic shock. Someone who got hit in the spine, for example, at the level of T4, and now they lost their control of the sacrum, they lost control of their sensations, they lost control of everything. They're gonna have a neurogenic shock. Now, keep in mind, a neurogenic shock is usually gonna have bradycardia, and that's one of the key ways that you're gonna actually recognize that on an exam. Anaphylactic shock, you're usually gonna be usually keep in mind that the patient has to have wheezing, right, or angioedema, like something remarkable to point that out. Oh, okay. So the high yield point, just keep in mind, if you have the jugular venous pressure, it's like flat. So you got a flat JVP. That's usually hypovolemia. There's not enough blood going around. You have high GVP, high pulmonary with pulmonary edema, that's cardiogenic. Obstructive, you have someone who's got clear lungs. Okay, that means there's no obstruction of the pulmonary arteries. Sorry, that means there is no obstruction of the pulmonary arteries. And high JVP, okay, that means like there isn't adequate draining to the right side of the heart. That's basically a right side heart problem. You have to think in terms of an obstruction situation like PE. Warm shock, that's septic. Bradycardia, neurogenic. Airway or rash, wheezing, any of these words, angioedema, that's anaphylactic. So here's a sample question. A patient, 76-year-old man, okay, that means he's an old person. That means the very high chance of having cardiac problems or having diabetes, hypertension, usually as comorbidities. You can have that like in an exam question. Found unconscious, okay. I checked his pulse. His pulse is 142. Okay, blood pressure 75 over 40, right? That means he's shocked and he's tachycardia. Doesn't open his eyes. Extremities are cold. Okay, capillary fill time is prolonged, 4 seconds. Okay, he's intubated on mechanical ventilation, pulmonary artery cath. You find an increased CVP, increased pulmonary capillary wedge pressure. All right, that's it. When you find an increased pulmonary capillary wedge pressure, the problem is in the heart. Increased systemic vascular resistance, I would expect that. All right, so that's definitely a cardiogenic shock. Thank you.